This talk is on how to handle malposition IOLs, which is really in the absence of capsular support, because we all understand that if you do have capsular support, then there is no question about where intraocular lenses belong. The important thing for this is, again, the conclusion slide is first. It's important to recognize the different stages of support, and that dictates how you're able to get an intraocular lens fixated in the eye with some stability. If there's an intact posterior capsule, or if there are torn zonular fibers, then often you can get a posterior chamber lens where it's supposed to be. If you're missing posterior or anterior capsular remnants, or if there's no capsule, then it becomes more problematic about how you can get a lens implant in. In the case of dislocated lenses, you really need to take the lens out. It's a little bit hard to suture in a lens because frequently that compounds the problem if the lens is already dislocated. In a way, there was a former governor of Kentucky that said there's no educational value the second time you get kicked by a mule. So if a lens has been dislocated or lost or out of position, then frequently you need to start over again and get it placed in the right position. An anterior chamber lens is probably the best way to go for a dislocated posterior chamber lens. And anterior chamber lenses got a bad rap early on, but many anterior chamber lenses, such as these early types, a Leitsky lens and a choice lens, have done very well and served patients for years with good vision. Now, we know about the UGG syndrome and all the problems that come with anterior chamber lenses. I'll discuss those in just a minute. Posterior chamber lenses can be placed with no capsular support. They can be iris sutured, as you see on the picture on the left. And Transclerally sutured posterior chamber lenses is my favorite procedure for patients that have no capsular support at all and have iris irregularities. The advantage of an anterior chamber lens over a sutured posterior chamber lens or an iris sutured lens is that it's something that everybody can do. It's faster. You can frequently avoid vitrectomy, and there's some wisdom in doing the simplest procedure for the patient. So if you have no posterior capsule and a reasonably normal iris and angle, then I think it's a no-brainer that an anterior chamber lens is where you should go. And in a patient that has a severely dislocated posterior chamber lens, I usually just take out the posterior chamber lens and we'll put in an anterior chamber lens. And the new 4-point fixation anterior chamber lenses are really hard to find fault with. The complications such as PAS, UGG syndrome, and cystoid macular edema frequently had to do with the finish of the lenses or the surgical technique and operative trauma. A study at the Mayo Clinic about 20 years ago looking at lens implantation found that most of the complications seen were related to surgery and not to the absolute design of the lens itself. And the new anterior chamber lenses that are currently on the market are really pretty good. And those of us that are gray-haired still have a prejudice against anterior chamber lenses that perhaps younger surgeons don't have, but I think I'm getting over it. Iris sutured posterior chamber lenses avoid the external sutures that you frequently have to deal with Transclerally sutured lenses. They avoid the complication of anterior chamber lenses if you don't have angle ease, in other words, if there are angle abnormalities or angle recession. They're somewhat technically challenging and do require enough intact iris to support the lens. There is iris contact with the IOL, and so problems like CME or hyphema or pigment dispersion syndrome have to be on your radar screen. But again, you're trying to give a patient vision, and frequently the CME, hyphema, and pigment dispersion syndrome has to do with the technical implantation procedure and not the fact that maybe you picked the wrong procedure to perform. The most common indication, I think, for needing a lens implant for when you have no capsule is when you're doing unplanned you have unplanned loss of the posterior capsule at the time of cataract surgery. Frequently, this is with a small incision surgery, and we still keep some of the Prolene loop posterior chamber lenses over in a small corner. This is I have no proprietary interest in any of the lenses that you may or might not use, but an acrylic lens with PMMA loops is helpful because here's the way that you can get a posterior chamber lens in when you lose all the capsule at the time of cataract surgery. You can fold the lens with loops in line. This is not the old mustache fold, but it's folded axially like you see here. And then you use the folder to push the lens into the eye through the small incision that you've made. passing the lead loop behind the iris, and then unfold the lens inside the eye in the anterior chamber so that your lead loop is behind the iris and the optic of the lens is in front of the iris. And then you place the trailing loop behind the iris so that you end up with a cat's eye figure like you see here, where the optic is in front of the iris. The pupil is distorted by the loops, and you now have to get the lens into the desired position and then use a mechanical suture to suture the PMMA loops to the back surface of the iris. Now you're thinking, well, doesn't this cause all kinds of trauma to the iris? Well, most of the pupillary movement is in the central 50%. So if your iris sutures for the lens are in the outer 50% of the iris, there is much less iris chafe, and the sutures don't necessarily erode through if you quit following the patients. All sutures eventually erode, and we'll discuss that in a minute. But for short-term solution, this is a good way to leave a patient with pseudophakic vision. You can support the lens with the cannula through the small incision, use a large needle, pass through the cornea, through the iris, behind the loop of the lens, and then back out through the cornea in a typical mechanical suture pass. You then cut the needle off of the suture and collect the suture with a Sinskey hook or an iris hook and pull it back out, and then you tie the suture using tying forceps through your incision, sliding the knot down onto the iris. Kelman-McPherson forceps are the tools of choice for doing this, and you do the same procedure for the other loop. And then once you have both loops tied and are certain that the knots are secure, you can then prolapse the lens back behind the iris, leaving the optic in the posterior chamber and the lens in the posterior chamber. And again, as long as the sutures are in the outer 50% of the iris, there's only minimal chafe because there's no pupillary movement, generally speaking, in the outer part of the iris. However, the knots need to be secure because they are the only support for the lens implant that you've got. And if the knot becomes untied or cheese wires through the iris, then the lens is dislocated. And at that point, I would go back and put in an anterior chamber lens as long as the angle is normal. But I do prefer a posterior chamber lens to an iris sutured lens. To an anterior chamber lens if all things are equal otherwise. Let me talk about Transclerally sutured posterior chamber lenses, which give you the advantage of not depending on iris, and you don't have to worry about iris sutures that may or may not cheese wire through. You also minimize any pigment dispersion, and it also minimizes any potential risk to the endothelium since you've got the lens sutured in the posterior chamber. IOL calculations should be noted to be slightly, you want the lens power to be about a half a diopter less because this lens is anterior to the capsular plane, which is frequently where your IOL calculations are expecting the lens to be. Transclerally sutured lenses have disadvantages because they're technically difficult to do. It takes more time. There's also the potential dislocation if the sutures erode. This is an eroded suture that you see in the picture on the right. And the treatment for an eroded suture, I think, is to use either a irradiated or a glycerin-preserved corneal segment, because if you take a small pledget of corneal tissue, take up the conge, make certain the knot is secured, you can then place a piece of corneal tissue over the top of it. It's approximately 50 to 25% thickness. Lay the conjunctiva back down over it. That will protect the knot, protect the conjunctiva, and allows you to see the knot all the time to know that it's still there and tied securely. Anytime you have a transclerally sutured lens, it's important for the patients to be followed a long time for erosion because, again, you never say never, and we figure that all sutures are going to lyse or break or untie or erode at some point if you follow them long enough. The ones that haven't succumbed to these complications are simply the ones that we have not followed long enough. The Transclerally sutured lens technique, I'm not sure I'm going to spend a lot of time with because I'm sure that Sadir has got everyone here well schooled and trained in this. I've heard his talks on the same subject and appreciate giving my 2 cents worth to his. But the fact of the matter is you use a double arm needle so that you can rotate the knot back down below the level of the sclera. A 3-strand knot does not work. And initially when this procedure was devised, we thought a 3-strand knot would be fine because the lens would fibrose in place, and then you could take the knot out. That doesn't work. And I'll show you why in the next slide. But you want to use a lens that has a loop at the end, and using a double-arm needle gives you a chance to pass one needle through and then the second needle through, and you can kind of seesaw the suture to know that it's rotatable. Because the worst thing to do is to tie your knot and then you can't bury it below the surface of the eye. For this reason, I also use a partial thickness scleral flap, as well as using a double-armed suture to rotate the knot below the surface of the flap and then put the flap down over the suture. So ideally, you can't see the suture or the knot because it's below a scleral flap. We know that the ciliary sulcus is about 11 millimeters in diameter, and it's posterior to the surgical limbus that you see from the outside. And so a posterior chamber lens, if you're passing a needle from the inside of the eye out, it ought to exit not 2 or 3 millimeters posterior to the limbus because that's in the pars plana. Vertically, it ought to be about 0.8 millimeters, and horizontally about 0.5 millimeters posterior to the limbus, because the sulcus is a lot closer to the limbus than you might imagine. And it's hard to pass a needle from the inside of the eye out and have it come out in the right place. You tend to be more posteriorly oriented, as I will show you. Now, this is why I say that where you put the sutures is ultimately going to determine where this lens is. This was a lens that was perfectly positioned postoperatively. Clinically, it was believed to be in the sulcus, and I thought that I had done a nice job on the case. However, the patient died of a pulmonary embolus about 3 weeks after surgery. We were fortunate to get the eyes for post-mortem. And you can see that the lens loop here is back on almost to the pars plana. And so did I pass the needle wrong? Well, not exactly, because if you look real carefully, you can see the tenoproline suture is around the loop, and here it goes up to the ciliary sulcus. So the needle pass was made in the ciliary sulcus, but the lens was not placed in the sulcus at the time of implant surgery. And that just means that this is a ticking time bomb. The suture alone is what secures the lens in place. And the important thing to remember is these sutures are not going to last forever, and maybe we think they will last for your lifetime or the patient's lifetime. That's good. But there's no guarantee that these sutures are going to hold the lens in place forever, and that's the reason I think that an anterior chamber lens, if you can use it, is probably the safest way to go for long term. There's only been one prospective randomized study looking at anterior chamber lenses and sutured posterior chamber lenses and iris sutured lenses, and that was 20 years ago by Shine, and he showed no difference in the three techniques in terms of visual acuity, complications, glaucoma, or CME. The modified capsular tension ring, I think, has a place in the use of implanting lenses if you have a dislocated lens because of zonular dehiscence. And as Sadir probably would tell you, I generally go on and suture in a posterior chamber lens because if you're going to pass sutures through the sclera, you might as well have the lens sutured in place rather than suturing the capsule in place and then trying to put the lens in the capsule. So by and large, the suggestions are if you have no capsule, an anterior chamber lens is the easiest way to go if the iris is normal. An iris sutured posterior chamber lens is the way to go if you've got a small incision and need to implant an acrylic lens. And a Transclerally sutured lens is the only option if there are absolutely no other ways of getting pseudophakic support. I would like to leave you with the fact that surgeon preference and comfort is the most important thing. Aphakic spectacles still allow people to see and shouldn't be shunned. And the clinical findings, the long-term risk of suture erosion and the eventual risk of suture lysis ought to drive what we do. And certainly the age of the patient makes a difference. I might do some things in an 80-year-old that I probably wouldn't do in a 20-year-old. Most importantly, stay within the comfort level. I would like to thank you all for your hospitality here. This is my first professional visit to the Wills Eye Institute, and I hope I have represented Lexington, Kentucky well.